Good morning. I am Justina Hinterberger, and today I will be presenting on perinatal mental health and advocacy for that. Obviously, moms are very important to all of us. We all came from one, lots of us are one, and they impact pretty much every client that we will see. So I feel like when we heal moms, we have the ability to heal pretty much everyone. So I'm going to share my screen if I can find it. There it is. Doo-doo. Some of the topics that I will be discussing today is obviously an introduction, a little bit about me, a definition of the perinatal period, why I feel like it's important, the PMADs explained, how we typically diagnose them, and how we as therapists can help. So again, I am Justina. I am a clinical mental health counselor here in North Carolina. My office is in Cornelius. I have researched and worked with this population since about 2015. And I myself am a mother, which is part of the reason why I'm so passionate about this. And I have four amazing kids. The whole reason that I got interested in perinatal mental health was that after I had my second daughter, I was at a mom's night out and there was a new mom who had just gone to her 6-week checkup and she had gotten the Edinburgh postnatal depression screener. And she was really concerned and worried that she got this screener and she thought the doctor was on to her, that they knew something was wrong. So she asked everyone else, first and foremost, if this was a normal thing. Is this a normal thing that everybody gets this? We all assured her that it very much is. And then after that, she asked if she was the only person who was lying on this screener. So she was very forthright on telling all of us moms that she had lied on this because she was really worried that they were going to know that she didn't feel quite herself and they were going to take her baby. And of the more than a dozen moms at the table, almost everyone said that they also didn't feel like they could be honest on this screener, which spurred my desire to want to go back and finish my undergrad in psychology and study women's mental health and perinatal mental health. So there is a huge disconnect with how we diagnose, which I'll talk about later, and how we actually come about treating postpartum depression and other perinatal mood and anxiety disorders. So to start, I have some motherhood myths. These are some of my favorite things. Number one, every pregnancy is expected, wanted, and excitement is the only acceptable emotion. No, anybody who is a mom knows this is complete nonsense. But I feel like the majority of folks in society who are not moms feel like, oh, you should be so happy to be a mom. You should be so grateful. It's exhausting, it's tiring, and there's so many emotions that come with being a mom that excitement is almost never the top emotion. Number two, this kind of plays right into that. Bonding with the baby is instantaneous. Some people bond with baby in the womb. Some people do bond with baby when baby comes out. Other times it can take weeks, months, years, and things like perinatal trauma, which I'll talk about in another presentation later today, can absolutely affect this. So there's a lot of factors involved, and this is also not the norm. That bonding with baby is not instantaneous, and sometimes it takes time. Number three, since breastfeeding is natural, it should be easy. Again, if you're a mom, you know that this is usually not the case either. It's awkward, it's weird, especially the first time. It's figuring out this tiny thing in your body and the new things that it's doing. It's not typically easy. It's really tough.
The recording is still paused. I just noticed.
Oh,
I can probably hit the button.
yeah, it started on my side, so it's recording for me. which is
It might be recording locally to your computer and you might need to send it, but I'll try and record here as well just for backup.
okay. Should I start over?
You're okay.
Okay. All right. And myth number 4 of motherhood, the good mother. This is the idea that you have to be what a good mother is, that you have to be a Pinterest mom, or what moms look like on social media, seeing the highlight reels of all the joyful, beautiful things that we're doing for and with our children 24/7, when this is not realistic. This is not the real idea of motherhood. And typically, I hear almost every client talk to me about, well, I see so and so and this person on social media, and they're so happy and they have this beautiful idea of what motherhood should be. And when it's not, they feel like they're failing. They feel like they're failing themselves and their children and their partners, when it's a completely perpetuated myth by primarily social media. So I implore almost all of my clients to share not only the good moments, but the crazy moments, or the things that seem crazy at the time, but then are really funny afterwards. Share those with the world. The more you share, the more, and be vulnerable, the more that other people will share those as well. And hopefully we'll stop seeing just the highlight reels. All right. So when exactly is the perinatal period? There are a couple of different definitions, but the folks that I have trained with in the research that I've done, the most effective definition of this starts at preconception. So there's a lot of moms who are in the realm of trying to conceive, and this will include any type of natural means of trying to conceive, any infertility struggles, oh my goodness, can't speak today, any type of infertility struggles, anything like that. Some women, it begins as soon as they find out they're pregnant. Sometimes that's with unintended pregnancies. So we like to say it begins with preconception, when women start trying to conceive, or when you find out you're pregnant, all the way through 1 year after birth. So obviously this period can be very long. In best case scenarios, about 2 years. Some women, it can be several years, and there's a ton of things that can happen within this time. Why are perinatal mood and anxiety disorders so important? Again, every one of us came from a mom, and this affects all of us. Women who have perinatal mood and anxiety disorders have a higher rate of infanticide, homicide, and suicide, relationship problems and divorce, child neglect and abuse, developmental delays in children, behavioral problems in children, and then it also accounts for a lot of disability and unemployment when these women are suffering silently. There are a lot of health disparities and inequalities that lead up to how we diagnose. A lot of that has to do with racial and ethnic disparities, sex, gender, sexual orientation and identities, disabilities, pre-existing health conditions. Socioeconomic status is really important in perinatal mood and anxiety disorders. Women who are of low SES are 11 times more likely to develop postpartum depression. 11 times. That is crazy high. New mothers of color have rates of postpartum depression close to 40%. And that's nearly 2 times the rate of white mothers. And again, these are just the people that we diagnose. So I'm going to touch on this again. So these are just the people that are either scoring high on their Edinburgh postnatal depression scale, or are self-reporting that they're having these symptoms. Nearly 60% of Black and Latina mothers do not receive any treatment or support services for those perinatal mood and anxiety disorders. And this goes back into the racial ethnic disparities that we see some of this with Black and brown mothers who give birth. They unfortunately have poorer health outcomes after birth because they feel that they're not being listened to, that they're not taking their concerns as seriously as white counterparts. Then nearly 30% of American Indian and Alaskan Native mothers experience postpartum depression. So this equates to 1 in 5 overall, and 3 in 5 women of color that suffer from maternal mental health conditions. Half of them never receive treatment. Maternal mortality, suicide and overdose are the leading causes of death for new mothers. That is crazy. Suicide and overdose, they're the leading causes of death for new mothers. Annually, it's estimated that it costs us about $14 billion in untreated maternal mental health conditions. And this includes things like preterm births, health costs, child and behavioral development costs later on as they start developing. And then also in productivity loss. Some of these women who have impaired functioning because they don't recognize that it's a mental health condition that can very well be treated if they are able to reach out for help. There are a bunch of perinatal mental health conditions that risk the health of pregnant people and their infants. Women who experienced bipolar disorder, depression, or anxiety during pregnancy are 40% more likely to develop hypertension than those who do not. Women with untreated bipolar disorders are more likely to experience hemorrhaging and are almost 2 times as likely to have a preterm baby versus those without any mental health challenges. Pregnant women with untreated anxiety have a higher risk of preterm birth, low birth weight, and infants being small for their ages. Infants of women with untreated postpartum depression can experience long-term impacts on weight, length, head circumference, motor and cognitive developments, and sleep patterns. So this hops back to that other slide where we have to put the money forth to account for some of those cognitive and emotional delays that children have from moms not receiving adequate treatment in and after pregnancy. Women who experience PTSD during pregnancy have a higher risk of preterm birth and poor fetal growth. So this slide is a bunch of moms. All of them have suffered from some sort of perinatal mood and anxiety disorder. All of them have given me permission to share these things, but all of them are a vast array of images, and some of them look very happy, some of them are very raw and vulnerable. In this next slide, there are some of the many things that the moms on the previous slides told me, and also some clients that have given me permission to share, that they feel like they've never been so scared of anything in their lives, making choices that no one ever should during birth. One of the moms shared with me that she lost her mom just days before she had her child, and she was enveloped in grief, and she lost the only person that she wanted there with her during her birth. Had another client share that she was really confused why she didn't feel bonded to this baby. She was told she'd be filled with this unexplainable love at birth, and all through pregnancy, she kept telling people that it didn't feel real. She didn't feel connected, that she was shouting for help and no one gave it to her. And after her birth, she still had no connection to the baby. And as much as she told people this, they kept just reassuring her, you'll be okay, you'll be okay, it will come. Some other moms have shared they deeply love their husband, their friends, their family, and they can feel very happy moments, but they're still incredibly depressed at the end of the day. A mom with postpartum anxiety shared that she couldn't stop thinking about her baby dying. It consumed every innocent moment of her days. She could not stop thinking anywhere she went and anything she did of all the ways that her baby could possibly die and just how fragile they were. There's some more moms. I'm in here too. And a couple more quotes. One of the moms shared with me in one of the smiling photos said, that smile, it was fake. I was losing it constantly. I had never known this level of stress. She had had an infant at home and then had twin boys, one with special needs, and she was completely overwhelmed, but thought that she had to carry on this very happy face that all of her children had been born and went home and seemed on the surface pretty happy and healthy, but she was completely overwhelmed and felt alone. A new mom came to me and said she had never experienced any anxiety in her life and that she was about 8 weeks postpartum and she believed she was having a heart attack. She felt immense pressure in her chest, her heart was pounding, and she went to her doctor, and her doctor said, "Oh, that's just anxiety. It's not a big deal," and prescribed her uh, SSRI and sent her on her way. And unfortunately, this is a story I hear over and over and over again. So I kind of touched on this earlier when I talked about 40% of Black women who are diagnosed with perinatal mood and anxiety disorders, but 21% of women are diagnosed with some sort of perinatal mood and anxiety disorder. There are a whole bunch of them. It is not just the postpartum depression that we think of. There is the perinatal and postpartum depression. Lots of bipolar disorders that become known in and after pregnancy, perinatal and postpartum anxieties, then also the generalized anxiety, panic, OCD, and PTSD that also may come during the perinatal period. So some of the mood disorders, perinatal depression just begins during pregnancy, and then postpartum depression begins anytime after pregnancy and ends through 1 year after. And bipolar disorders. 60% of bipolar disorders in the perinatal period are misdiagnosed as major depressive disorder. And typically they only find this out similarly to any other time that bipolar disorders are diagnosed is when they give new moms SSRIs and they suddenly start rapid cycling and go into mania, which just further makes them feel more crazy. And unfortunately, a lot of moms feel that they can't reach out for help because there's something genuinely wrong with them and that they're going to take their babies away. This is something that I hear very often, that they're fearful that someone is going to take their child and then they're failing. So we've all heard of the baby blues. This accounts for about 80% of mothers experience baby blues. It's crying, feeling overwhelmed, being uncertain, kind of reactive, acute sleep deprivation and fatigue. This is something that peaks about 3 to 5 weeks after delivery and then steadily improves. So this differs from postpartum depression in that with postpartum depression, your primary mood is not happiness. You more often feel worried, sad, reactive. But with baby blues, you still have a primary mood of happiness. You just might be feeling overwhelmed or crying at certain points of the day, but then it feels improved and it will get a little bit better. So how do we tell the baby blues from postpartum depression or perinatal depression? Severity, timing, and duration. Does it resolve? Are there symptoms getting in the way of life? If it persists beyond the first 5 weeks of postpartum, and risk of postpartum depression peaks at about 3 months. So between that 5 and 3 months, we find most of the postpartum depression. In duration, it does not seem to end or improve with time, where baby blues will kind of shift up and down and then steadily improve after about 5 weeks. The next, anxiety disorders. This is something that we don't think of quite as often as the postpartum depression. A lot of moms and dads too experience anxiety for the very first time during the perinatal period or in the postpartum period. So again, perinatal or postpartum anxiety either just begins during or after pregnancy through 1 year. And then generalized anxiety, panic, OCD, they're very similar to what we diagnose in non-mothers, but they just specifically begin during the perinatal period and they've never experienced these symptoms before. And then PTSD. I have an entire presentation for my second hour on this, but there are an innumerable number of traumas that may occur in the perinatal period. So again, some of those moms who are dealing with infertility, pregnancy loss, I want you to think for a second about how long that period could potentially be. How many things in pregnancy could go wrong and feel very traumatic for mom. It truly is innumerable. There are a substantial number of things, and it's not just a traumatic birth. There's so many things as far as health, wellness, just scary things that happen during, before, and after pregnancy. So let's talk about some risk factors of perinatal mood and anxiety disorders. There, of course, is the biological aspect. If you have a personal or family history of mental illness, you have a much higher rate or likelihood of developing a perinatal mood and anxiety disorder. And of course, there's also hormonal factors. Lots and lots of crazy hormones are flowing through our bodies as moms, and this definitely impacts some things, and there's not a lot of concrete data on what exactly the hormones are, but it is being worked on. Those women who do stop medication during pregnancy have a relapse rate of about 68% for depression and more than 80% for bipolar disorders. So there are lots of medications that moms can take during pregnancy that are pretty safe, but lots of moms, again, feel that they shouldn't have to rely on these medications, especially during pregnancy. They don't want to affect their baby. But again, there are lots that are safe, and there are several psychiatrists who specialize in perinatal mood and anxiety disorders that can help meet with these moms and let them know that some of these treatments can help during pregnancy. Insufficient social support. Lack of family, community, friends, or partner support can absolutely play into the perinatal mood and anxiety disorders being more prevalent. And then insufficient physical activity. So I actually did a thesis about this in undergrad, and I was trying to prove that any type of physical activity would help lower the rate of postpartum depression, which was actually true. So any sedentary to low activity was at the highest risk. So if you were on bed rest, or if you just never got up and walked around and you worked in a sitting position and didn't do hardly any physical activity, you had a substantially higher risk of postpartum depression, where even if you walked for 5 minutes a day, 3 to 5 times a week, the instances of postpartum depression decreased and decreased with the more physical activity that moms did. And some of this seemed to be that obviously when you work out and when you're getting your physical activity moving, that you release some cortisol. So your body gets to recognize some of those cortisol levels and knows how to better react to it when it does happen. So it sets you up for success later. And again, this doesn't have to be crazy running a marathon. It's anything from going for walks. So walk around the block 3 to 5 times a week. That alone decreases the rates of postpartum depression, which is pretty fantastic. Something easy that if you feel not great about taking medication, get in a little bit of physical activity. Doesn't have to be crazy. Next, again, I talked about that increased stress. So during and after pregnancy, we face a tremendous amount of stress. Those increased cortisol and other stress hormones due to life stresses, all the life stresses, childcare stress, work and financial stress, marital satisfaction and status. The way that our relationships change after having a baby is significant, and it's all relationships. It's not just our partners. All relationships change after having a baby, and that can really impact us and make us feel really stressed. Again, earlier I talked about socioeconomic status and how those at or below the poverty line have an 11 times greater likelihood of developing a perinatal mood and anxiety disorder. Some of these things that lead up to this can be access to care, cost of care, being uninsured or underinsured. There's so many factors that play into this, but also very much the increased stress. Those who have an unplanned or unwanted pregnancy are 50% more likely to suffer from postpartum depression than those with intended or planned pregnancies. Another risk factor is difficulty conceiving. So again, some of that beginning of the perinatal period can be dealing with infertility. That can be very stressful, of feeling like your body is failing you, of all the money it's taking, the marital stress, the strain on all relationships. A lot of moms that I see struggling with infertility feel a tremendous amount of guilt, rage, all kinds of feelings against people in their life or random women that they see out pregnant and feel like it's not fair that their bodies can't do what they feel like it was meant to do. And it's difficult managing those emotions, especially if you're doing it alone. Again, some of the things that can happen during and after pregnancy, that some congenital or genetic health issues, birth traumas, or NICU stays. The highest risk of PTSD is in these parents that have babies in the NICU. Understandably so, it's very traumatic having your baby taken and put into the NICU and having some health concerns. Those are the highest rates of PTSD that we see in parents. And touch on this again later on, but this is not just in moms. Dads can also suffer from a lot of these perinatal mood and anxiety disorders. And then difficulty breastfeeding. The inability to breastfeed or difficulty breastfeeding after birth can absolutely be a risk factor of this, that again, feel like your body is failing you. It should be natural. It should be this thing that it was meant to do. Why can't I do it? What is wrong with me? All right. Lots and lots of factors that go into perinatal mood and anxiety disorders that are risk factors. So I'm talking about some prevention. The screening tools, as I talked about earlier, that we're using right now are not enough. Just handing the Edinburgh postnatal depression scale to a mom after she has a baby is not enough. Handing it to a mom at a pediatrician checkup is not enough. Know your clients' or your patient's risk factors. So ensuring you know the personal and family history, especially if you have a client who is trying to conceive or is thinking about having babies, this is very important. Then encouraging those clients to share with their care providers, whether it be a midwife, an obstetrician, whoever, whether they're trying to conceive, they're pregnant, or they're postpartum. Sharing those risk factors is very important so that they can also be aware to know what to look for. And next is network with providers and care professionals. This is kind of my realm of passion, obviously. So I've gone to a bunch of obstetricians locally and talked with lactation consultants and pediatricians about some of these things to look for. But I would very much believe that any of us, especially as women, when we go in to see our obstetrician, say, hey, how often do you talk to moms about postpartum depression? That leads into my next factor, psychoeducation. So psychoed, from nurses, OBs, lactation consultants, pediatricians, therapists, psychiatrists, literally anyone who helps this population can share this knowledge. You can let them know what some of these risk factors are, that they are at risk for it, what to look for. Let them know just how common it is. Most moms and dads who suffer from perinatal mood and anxiety disorders feel very alone, and they feel like they are the only people going through this, when it's very much not the case. Psychoeducation is shown by research to decrease shame and stigma of perinatal mood and anxiety disorders. It helps new moms and dads feel more comfortable when they are experiencing some of these things to go to the doctor and say, hey, this is what's been going on. So and so let me know that this is what to look for, and I'm feeling some of that. What should I do? Finally, resourcing. Ensuring parents to be or parents know where to go if and when symptoms occur. So like I just said, if you start feeling some of these things, that you feel more comfortable going to a doctor, going to a therapist and saying, hey, I have this going on, how can we help? And having resources on hand that are accessible for them. I'm going to share some resources on just some of the data from Postpartum Support International and some other assessment tools that we can use to talk to new parents or parents to be about some of these risk factors. Can non-birthing parents and partners experience perinatal mood and anxiety disorders? Yes. Postpartum depression, anxiety, OCD, and PTSD have all been proven to be present in many non-birthing partners and parents, also including adoptive parents. adoptive parents can feel a lot of these things as well. So, how do we currently diagnose? I touched on earlier the Edinburgh Postnatal Depression Scale, or the PHQ-9, can be given at the OB or at the pediatrician's office. Self-report. Many women report that when they have self-reported symptoms, they are dismissed as normal or just simply offered an SSRI to treat the symptoms. This is problematic for a whole lot of reasons, but especially being dismissed if clients are given psychoeducation and resources, then they're set up to be successful and not feel the guilt and shame and things that they may go on to feel otherwise. And then in the hospital and the ER, the hospital and the ER sees a lot of postpartum anxiety. Some of it is severe. Sometimes it's some of those people having anxiety for the very first time and thinking they're having a heart attack or that they're having a stroke or that there's something going on. They also see a lot of severe anxiety, some of that OCD where they have thoughts that they cannot let go of baby dying, of harming baby, psychosis, suicidal or homicidal ideation or attempts. Then these people typically end up hospitalized when, if they had gotten the resources during pregnancy or while trying to conceive, it could have prevented a lot of this. Obviously not in the realm of psychosis and in the suicidal or homicidal ideation, but a lot of the postpartum depression and anxiety. This is what, for those who are not familiar, this is what the Edinburgh Postnatal Depression Scale looks like. It asks, in the past 7 days, have you been able to do any of these things? And some of them are more severe. Obviously, number 10, the thought of harming myself has occurred to me. If somebody answers yes quite often, that's something we need to immediately assess for. But the Edinburgh Postnatal Depression Scale is honestly not something that I typically use because, again, it's not very effective. It is a completely ineffective tool without psychoeducation. When it's just simply blindly given to women, the majority of them feel the need to be dishonest on the survey. And then also, partners or non-birth parents feel they don't have the right to have a perinatal mood and anxiety disorder. I've seen some dads who are suffering with postpartum depression or postpartum anxiety, and they say, I'm not the one who gave birth. I didn't go through pregnancy. I didn't go through all of these hard things. I don't feel this way. I don't understand why I feel this way. I shouldn't feel this way. A lot of I shouldn't feel this way because they feel like they didn't earn the right to be suffering, especially when birth moms aren't suffering with some of those things. So how can we help? Here's where you come in. Psychoeducation. This is the most important piece of perinatal mood and anxiety disorders. The psychoeducation for families and medical providers. Anyone who talks to a mom, which is all of us, can let them know how normal this is. This is not something to be shameful of. This is not something to be scared of. Screening, asking questions. Ask more questions. Just don't hand over the Edinburgh postnatal depression screener. Normalize. Normalize just how often women experience some of these things. And not just women, again, dads, other people in baby's life. Breaking the stigma surrounding mental health in general, but especially for parents. And then training. Postpartum Support International is one of the oldest and, in my opinion, best organizations that provides training. They have everything from very basic training all the way through very advanced training that you can learn the ins and outs, the pharmacology, everything to do with perinatal mood and anxiety disorders. They're a tremendous organization and they offer free support groups for people all around the world too. So those who do not have resources to go to therapy, they have groups for pregnancy loss, for moms of color, for LGBTQ parents, for literally anything to do with perinatal mood and anxiety disorders, they've got a group for it. And if they don't, tell them and they will establish one. All right. And again, ask more questions. The screening tools are not enough here. For depression, we can ask things like, how are you adjusting to motherhood? We can gauge pretty quickly by a question like that how much they're struggling, if they're struggling. Have your friends or family met the baby? This has been huge during COVID, that a lot of babies haven't met friends or family because moms are very fearful, understandably. Next, how often do you find yourself crying? A lot of times I have new parents say, I've been crying. Okay, well, how often do you find yourself crying? Is it a couple of times a day? Is it all day, every day? Are you staying awake at night crying? Tell me more about the crying. Have you felt more frustrated or angry lately? A lot of postpartum depression does not come out as depression and being sad and crying. A lot of it is reactivity and anger, and a lot of it is in times where moms feel it's inappropriate for them to be angry, but they feel it's out of their control. So a lot of postpartum depression, again, looks like anger and looks like reactivity and not necessarily that sadness. As far as the anxiety, how are you sleeping? Do you sleep when the baby sleeps or when given the opportunity to sleep? So if your partner gives you time and says, hey, I'm going to take the baby between X and X so you can sleep, go and do that. Can you do that? If not, a lot of times moms are focusing on preoccupied thoughts and having difficulty sleeping because of postpartum anxiety. How much time have you spent worrying about harm coming to the baby? How often are you worrying about the future? And then some OCD things. Do you feel a need for things to be perfect or for them to be in a certain way or order? Do you feel the need to be in control of things? Have you had a hard time not doing things over and over? A lot of checking behaviors, a lot of obsessive compulsive type things post motherhood. Some of those are a little bit normal for health and safety of baby, especially when it's your first baby. But it can quickly go from checking every once in a while to becoming completely obsessed with it and not being able to sleep and not being able to function. So some primary interventions for postpartum depression. Many women report when self-reporting symptoms, they're dismissed. In postpartum anxiety, panic, and OCD, some of these interventions we can get after birth. Oh, yeah, we can find them most often after birth in that first checkup period with some of the questions that I mentioned on the past slide. As far as PTSD, this is most often presented at the first well baby check. And bipolar disorders and psychosis. Medical intervention is typically needed for bipolar disorders. If they're non-psychotic features present, connect to psychiatry. Hospitalization is always required for psychosis. It's about every 3 in 100 women who experience postpartum psychosis, but immediately we would refer them for hospitalization. Sooner we can get them there, the sooner they can get the help that they need. But when that happens, when they get the proper resources, they usually get back to normal pretty quickly. And earlier I talked about getting some of that additional training. So some training and support resources. Again, Postpartum Support International. There is 2020 Mom, which is another organization that is linked with PSI. They have measurable goals every year of things that they would like to achieve. And Mind Body Baby is a nonprofit here in North Carolina that connects moms with support groups, with resources, and also has funds for moms who are underinsured or uninsured to get therapy from therapists who are trained in perinatal mood and anxiety disorders. And then the Office of Women's Health, OASH, is national and it is through the CDC. Finally, I like to tell moms and all parents that are suffering, you are not alone. This is temporary. With help, you can heal and you can get better. Thank you. All right. Do you have any questions?
No, thank you for that. Well, I guess kind of one. Um, the what to do. So clients or people that are really struggling with particularly postpartum depression, right? Seeing, I don't think there's an answer, and that's probably why it's a question, is like, what's the trick to start to get things better?
Sure. So it's different because it's dependent on, I guess, kind of severity. So if it's someone who has experienced depression in the past, we can kind of assess for what are some things that have helped in the past. How can we assess some of those negative cognitions they have? With postpartum depression, a lot of moms focus on some of those negative cognitions that they've held most of their lives and then carried on and have been reinforced during motherhood, that they feel like a failure, that they feel like they're doing something wrong. It's those messages they've received all along that come back with a vengeance. So a lot of CBT interventions actually seem to be really effective with postpartum depression, things like thought stopping. Starting with recognize those negative thoughts. Start there. Write them down when they're happening. Notice how often they're happening, when they're happening. And then when they can start to do that, begin kind of challenging some of those. Like, is this legitimate? Is this something that is real? Is this thought something that's true? Or is it something that has been long reinforced every time there's a mistake? So again, with it through CBT, it's like we're focusing everything that happens in our lives through these negative cognitions. So once we can help new moms and dads break down some of those negative cognitions and recognize them and challenge them, it becomes a little bit easier.
I think it's so hard because, well, with sleep deprivation, motivation to change, right? And that's, I think, that postpartum period, the like not wanting to be depressed, but just wanting to, not wanting to, I don't want to say not wanting to change, but just not having the gumption or the energy to make changes. Like,
Absolutely.
it's almost, I feel like sometimes I see being happy is more exhausting. Like the potential of being happy is more exhausting than,
Right.
but I mean, you nailed all the hormones, like everything is happening at once. Postpartum just seems like the perfect storm.
It absolutely is. It absolutely is the perfect storm. And so many things can happen during that period, right? Which just increases the likelihood of a mental health disorder just compounding and coming to fruition. Yep. Focusing on a lot of identity issues too, I feel like is also important. We aren't the person that we were before we had the baby, and that's okay. We can never go back to that person again. But also, moms that I start seeing in pregnancy that start having some of these things, starting to set them up for success that, hey, you are developing a new identity. You get to decide who you want to be, what kind of mom you want to be. And definitely touching base with those self-care items. I have moms who do absolutely nothing for themselves because our primary function is taking care of our baby. Their happiness, their just livelihood is all on us, which is an incredibly stressful thing, but also we're important too. So even if you only take, some moms I start with 5 minutes a week, take 5 minutes a week, put it on your calendar if you have to, schedule that little bit of time to do what feels good for you. Sometimes it's absolutely nothing, sit in silence. Sometimes it's go in the closet and eat a candy bar by yourself and enjoy the silence and not having to share food with somebody. Sometimes it's going for a walk by yourself, journaling, reading, just something that feels like it connects with you, starting to do that in little increments and figuring out who you are again, aside from having this tiny person who needs you.
see many things.
All right, I'm going to go ahead and get started. Hey everybody, my name is Justina Hinterberger. I presented on perinatal mental health advocacy a little bit ago, and I'd like to talk a little bit more about perinatal trauma and perinatal trauma advocacy in this presentation. Oh no, I can't share my screen. All right, well, I will just talk about it. So, introduce myself. I am, again, Justina Hinterberger. I am a clinical mental health counselor here in North Carolina. I specialize in women's mental health, and in that comes with perinatal mood and anxiety disorders. And I also specialize in trauma. I am EMDR trained and advanced trained in perinatal trauma, and that's some of what I'm going to talk about. Okay, all of what I'm going to talk about today. And again, I am a mom of 4 amazing kids, which is why I became so passionate about this and moms. So, to start, I would like to talk about some myths in motherhood. I mentioned this in my previous presentation, but I'm going to do it again because it's a thing. Like, we believe that motherhood is this great, amazing thing, and it's tough. So, the first myth that I have on this presentation, which I'll go ahead and upload that so y'all can see this as I'm talking later. Every pregnancy is expected, wanted, and excitement is the only acceptable option. Emotion, apologize. It's the only acceptable emotion is excitement, happiness, joy, right? Becoming a mom or a new parent in general is terrifying. There's so many emotions that come along with that, and not all of them are positive. That is normal and that is okay. Myth number 2, bonding with baby is instantaneous. Again, this is not always true. It is more often than not something that new moms struggle with, especially if we have issues breastfeeding or if there are health complications or if babies in the NICU. There's so many factors that go in here. And it's not this instantaneous thing always where a baby comes out and we are filled with this love and joy and it's amazing. It's not a realistic myth to keep perpetuating. Number 3, again with breastfeeding. Since breastfeeding is natural, it should be easy. Anybody who is a new mom and has attempted breastfeeding knows this isn't true, right? It's awkward, it's weird, trying to figure out where the baby goes, where you go, how does this work? And figuring out our bodies and the way they adjust and continue to adjust after baby comes, it's difficult. It's more often than not easy. It doesn't come naturally or easily to almost any moms. Again, that is okay. And if you choose not to breastfeed, also okay. I like to say fed is best. Is your baby eating? Perfect. That's all I need to know. I don't need to know how. You choose that for you. There's so many factors that go into it. That's okay. Last myth, the good mother. This is one of my biggest pet peeves, in every single mom that I've ever met with has mentioned social media and the idea of what a good mom is. A good mom is a mom who loves and shows up for their child and meets the needs of their child the best they can. The good mother that we see on social media is this always happy, always on, perfect looking mom who does all the things and has the Pinterest parties, and that's not realistic. We see the highlight reels on social media. It's not real. I very much encourage every single one of my clients, whether moms or not, to be vulnerable. Every once in a while, not all the time. You don't even have to do it all the time. Once in a while, be vulnerable. Share real life experiences, how you're feeling, what's going on with you. Always, when I have had people do this, I have people respond either publicly or privately and say, hey, I really appreciate you doing this. It made me feel like I wasn't alone. It made me feel understood. It made me feel seen, right? That we're not in this alone, especially this motherhood thing. It feels very lonely. It doesn't have to be. Right, next, when exactly is the perinatal period? So there's some variance in this depending on who you talk to, but I myself, in the research that I have completed over the past 5 years and the folks that I have trained with, we all very much agree that the perinatal period begins either in those who are trying to conceive. It starts at that point when you start trying to conceive through 1 year after birth. Not every pregnancy is expected or wanted, as we mentioned earlier. So, with those expectant moms, it would be from the moment that they found out that they were expecting through 1 year after birth. And that is the greatest variance for me. So, what exactly is perinatal trauma? It's any traumatizing event or events that occur during that perinatal period. So, I want you to take a moment to think about that perinatal period. So, best case scenario, right? That you start trying to have a baby, you get pregnant right away, and you have a baby in the year after. So, a little less than 2 years, right? So, even in that period of time, I want you to think about how many traumatic things can happen to mom, baby, spouse, anything in that period. Trying to conceive in itself can often be very traumatic. Pregnancy loss is very traumatic. Health complications, so many things, traumatic births, baby being in the NICU. A lot of traumatic things can happen in the perinatal period. So, why is this so important? Well, all of us came from moms, right? Moms are the foundation of everything that we are and who we are. Even if we grew up without moms, that we came from them. And the health of moms, I think we can all agree, is very important. And when mom is healthy, she can spread those healthy habits down to children, onto spouses, onto friends, onto colleagues, onto everyone. When we take care of mom, that care spreads to everyone. So I feel like foundationally, moms are very important to care for. There are a lot of health disparities and inequalities that play into perinatal trauma. Earlier in my first presentation, I talked about how a lot of Black and Brown moms we know have poorer health outcomes during birth. Black, American Indian, and Alaskan Native women are 2 to 3 times more likely to die from pregnancy related causes than white women. That's insane. That is absolutely insane. And over again, we hear that doctors are not hearing the concerns of these women when they say they're experiencing a lot of pain, when they feel very off, and they're brushed off and made to feel like it's all very normal. It's not normal, and we need to do better. Pregnancy related deaths per 100,000 live births for Black and American Indian and Alaskan Native women older than 30 was 4 to 5 times as high as it was for white women. What? That is us failing moms and failing their children. Some of the other things that go into this and some of the disparities and inequalities include sex, gender, sexual orientation and identity, having a disability, pre-existing health conditions, geographic locations, and socioeconomic status. 25% of women that are in the low SES bubble, they begin prenatal care late. This rises about a quarter of the women of low SES begin prenatal care late. This rises to 34% among Black women and 41% among American Indian and Alaskan Native women. So all of these women are starting their prenatal care late. So they're not starting prenatal care when they're first finding out that they're pregnant. Some of them are not starting it until they're going into labor. Some of them are not starting until 12 weeks, 20 weeks, 25 weeks. This is so important that we need to do better as a whole to get these women care. Did you know that about 45% of new mothers have reported having a traumatic birth? And while I shared earlier that a traumatic birth is not the only type of trauma that someone can experience during the perinatal period, this is significant. That's almost half of new moms experiencing a traumatic birth. That's scary. That's really scary. My next slide is some pictures of new moms in motherhood. One of the most impactful things that I have on this slide, I feel like, and I want to tell a story about, is in the top left. There is a new mom with her silhouette in front of the Christmas tree. And she reported to me that this felt very lonely. It was during this past Christmas during COVID, and she was pregnant, and she felt more alone than she had ever felt in her life, that she was detached. That's really scary. So, a lot of the things that we've seen on a whole for postpartum depression, anxiety, all perinatal mood and anxiety disorders, right, have all been heightened by COVID, especially the sense of being alone in isolation, because we are. So while we can connect virtually, being in person can account for a lot for moms to not feel like they're disconnected alone. And when they don't have that physical support from friends or family, being a new mom can be really, really hard. And there's a little shift here that I want to start shifting into trauma mode here and away from the perinatal mood and anxiety disorders as a whole. So I have a quote from one of the most amazing women in the perinatal mental health realm that I've ever met, Dr. Mara Tesler-Stein. She developed the advanced perinatal mental health EMDR protocol and training, which is incredible just in and of itself. But she is amazing. The quote says, "Trauma creates disruption in normal information processing, resulting in unprocessed information being dysfunctionally held in memory networks." So while this is true for all trauma, I feel like it's particularly important for moms, because when those traumas happen in the perinatal period, it carries on afterwards, and we carry that through motherhood unless we pull out some of that trauma and treat it. In this picture, that again you can't see, is the triune brain. So I'm going to, since you can see me, I'm going to use Dan Siegel's handy model of the brain. Right. So we have our hand here, and I fold in our thumb. So I want you to think of this part of the hand, the palm, and into my wrist, as the reptilian brain. The part of our brain that holds the reactiveness, that holds the feelings in our body, all of our autonomic nervous system, the stuff that's automatic, right? And then the middle part of my hand here, I want you to think of this as the limbic system, or the mammalian brain. So that is the part that is most responsible for emotion and emotion processing. And then up through the front here, I want you, I'm doing a terrible job here. You can't see my hand. Up top here, we'll see the frontal cortex, right? Or the neocortex. This is the part that is information processing and where we have our cognitive thoughts. So with the triune brain model, think about trauma and it being stored in this limbic area of our brains that is reactive. So we don't often think about things before we react to them when we're storing traumas. It's in when we are able to process traumas correctly, we can process them out through the frontal cortex and hold them in our memory networks in that somewhat part of our brain. So we can feel a little bit of emotion about it, but it's not held in that central part of our brain, so we don't feel reactive about it. So when we are triggered or we have a trauma response, this central part of our brain becomes really swollen with blood flow, so it can become reactive, and it happens quickly. And that does a thing that Dan Siegel calls flipping our lid. That neocortex, that frontal lobe, essentially goes offline. So when somebody is having a trauma response and they say they feel like they can't have normal thoughts, they can't think something through, it's because they can't. They genuinely cannot. That cognitive part of their brain is not fully functioning, and they cannot. So what do? I'll get into that in a second. Just want to give another figure. Did you know 1 in 20 mothers show signs of PTSD at 12 weeks postpartum? 1 in 20. And then overall, for the perinatal period, 10% of mothers experience perinatal PTSD. And some of those symptoms look exactly like traditional PTSD, the intrusive thoughts, nightmares, avoiding reminders of the event. So I want you to think about this. And I had this up on my quote slide that you can look at later on. But I want you to think about this. If somebody has PTSD and they're avoiding reminders of the traumatic event, when their child is the reminder of that traumatic event, of a time when they almost died, of the time the baby almost died, you're constantly reminded of this traumatic event and constantly feeling overwhelmed and sick and that you can't function when you look at your baby. I want you to imagine just how terrible of an experience that would be for a mother every single day, every single moment of every single day. It's awful. It not only gets in the way of them being a mother, but it gets in the way of them being a human, of functioning at all. It's tough. Again, a lot of the other symptoms exactly the same as the way we diagnose normal PTSD: the insomnia, flashbacks, difficulty concentrating, hypervigilance, self-isolating, anger and irritability, reduced interest in their favorite activities, avoiding people or places related to the event. Again, if that is a baby and or the doctor, you're not going to go to that doctor for help. And you're going to have a really difficult time caring for your baby. And then lastly, difficulty feeling positive emotions. Again, think of this cycle and the spiral this can go down if your baby is the reminder of your trauma and you're feeling constantly triggered by caring for your child and really wanting to feel those positive emotions. And you just can't. You can't feel those positive emotions. Next, I have qualities of perinatal PTSD. Overwhelming fear. Fear regarding parenthood, the baby or babies, repeating the experience, seeing the providers again, and feeling a loss of control. Next, shame and humiliation. Feeling betrayed by our bodies, by our providers, feeling as if something is wrong with us. Foundationally, something's wrong with me, that this didn't go the way it was supposed to go. This is something my body is supposed to do. It's what I'm made to do. I'm a woman. This is what I'm supposed to do, right? So what's wrong with me that it didn't? What did I do wrong? Intrusive interventions. During labor and delivery, drug or physical interventions without consent or no explanation. Loss of peer group. Self-isolation, disorientation, depression, anxiety. All of these things are qualities of perinatal PTSD. Next, I have a slide I begin the 4 different realms of the way that we kind of conceptualize periods and when perinatal trauma can happen. So the first of those is in trying to conceive or becoming pregnant. First one is infertility. So there's so many things that can go wrong in here or that feel traumatic. There are so many medications, injections, intrusive tests that go on during trying to conceive and when you're experiencing any type of infertility. Also, using a donor egg. This can be very traumatic. Next bullet point here is adoption. adopting after infertility, or also being a birth parent and deciding that your baby would be more well suited with someone else. Imagine how traumatic that is, going through an entire pregnancy knowing that, or deciding that after birth. That all can be very traumatic. The next bullet point here is surrogacy, either utilizing a surrogate or being a surrogate. There are a lot can go on with either of those things that can be very traumatic. My next period is complications during pregnancy. So pregnancy ideally is 40 weeks. The point of viability, for a baby nowadays is about 25 weeks. And each week after that, the point of viability and success of baby going on to grow and be healthy gets better and better and increases in likelihood of doing so with every week, quite literally. So complications during pregnancy, not just that preterm labor, but there's medical issues that can happen with mom. You can develop preeclampsia, HELP syndrome. You can develop a molar pregnancy. So for those who do not know, a molar pregnancy is a pregnancy that it has a clump of cells that develop, but it is not an embryo. But you still throw pregnancy hormones, HCG, off, so you get positive pregnancy tests. But when you go in for an ultrasound, you just see these cells that don't develop into anything. Sometimes those molar pregnancies can develop into cancer, which is also very scary. Placental abnormalities can happen with mom. So many different things can happen with the placenta during pregnancy. So it can be placenta previa, placenta stops developing, just so many things. Medical issues with the baby or babies. There's twin-to-twin transfusion syndrome. So when twin pregnancies occur, you have a lot of ultrasounds, and that's for a lot of reasons. But twin-to-twin transfusion syndrome is a severe and life-threatening medical issue for the babies and can also be for mom. Congenital genetic syndromes. Lots of times we find out about some of these in babies during pregnancy. And then we can also be faced with babies not being compatible with life. Imagine carrying a pregnancy to term knowing that your baby won't be coming home with you. Lots of other complications during pregnancy. Again, earlier we mentioned preterm labor and ectopic pregnancy. An ectopic pregnancy is a pregnancy that happens outside of the uterus and can be very dangerous for mom if not caught right away. Moms can die. And contrary to some ignorant things said as of late, ectopic pregnancies cannot be removed from other places in the body and moved into the uterus. That's just unfortunately not how it works. If science develops for that to work somehow, someday, that would be very cool. But that's not how it works. That pregnancy always needs to be removed and terminated because if it continues to grow, it can be fatal for mom. Next period is complications around birth. Again, earlier I mentioned almost half of births were reported as being traumatic. So a lot of things can happen with complications around birth. First bullet point is delivery. Again, we're touched back to preterm delivery. Preterm delivery can be very traumatic and scary. A baby is coming before 37 weeks, which is considered full term. Anytime before that, it's preterm. It can be very scary not knowing if baby will be able to breathe when they come, if they'll be okay. So many scary things with preterm delivery, especially if it's a very early preterm delivery. Next, again, that preterm labor and delivery. using medical interventions, tools, things that feel very intrusive to moms can be very traumatic. Next, an unwanted, unplanned emergency cesarean section. It's a major surgery, especially when you go in not expecting it to happen or it needing to happen immediately to save mom and baby, or either. It's very scary. It can be very traumatic. It can help develop some fear, some anxiety around, what did I do wrong? Could I have prevented this? What's going to happen to my baby? Is my baby going to be okay? Medical complications with mom, excessive bleeding, uterine rupture. If your uterus ruptures, it can kill mom and baby if not found immediately. Then things like perineal tears and cuts. Those are very traumatic things for mom. Then, of course, medical complications for the baby or babies. Fetal distress. During labor and delivery, a lot of times when fetal distress happens, you're rushed to an emergency C-section, get those babies out immediately. After birth resuscitation of baby. And then I also have meconium aspiration mentioned because that's something that is really scary. That first excrement that a baby releases is meconium. It's a very sticky, tarry substance if you're not familiar. Sometimes during birth, baby can have that first bowel movement in utero. If that happens and they do aspirate it and it gets into their lungs, it can be very dangerous. So, infections can happen, breathing problems can happen. So, that's a very severe medical complication. It's very treatable, but it is very scary, and very scary when birth and delivery otherwise look very normal and okay, and then baby comes out with this issue that needs to be treated. Finally, the fourth period that is highlighted here for potential traumatic periods during the perinatal period is death of a baby. This includes a miscarriage, a pregnancy interruption for poor prenatal diagnosis. So earlier I mentioned carrying a pregnancy to term when you know you won't be bringing baby home. Some mothers choose to terminate their pregnancies when they're incompatible with life. Imagine how traumatic. Things like stillbirth, neonatal death, which is death after birth, neonatal illness, a NICU stay that ends in death, or SIDS. Then things like accidental death. All types of accidents can happen, car accidents, just so many things can happen to lead to accidental death. Obviously, this is very traumatic. And then I also have highlighted perinatal hospice. So perinatal hospice is something that happens after birth when parents are aware or become aware after birth that their baby's conditions that they may have are incompatible with life. There is a perinatal hospice service that allows baby and parents to be very comfortable and together as baby passes. While the service exists to try and reduce the amount of trauma inherently, just the death of a baby is very traumatic. Let's talk about some risk factors for perinatal trauma. First of all, perinatal PTSD can be heightened by having a personal history of trauma. This is very important to assess for trauma, especially ACEs. There's a lot of things that clients don't conceptualize as being traumatic, but when you kind of break down definitions of it, they very much can hold some of these things. And then it can be reinforced during this perinatal period. Next, insufficient social support. Lack of family, community, friends, or partner support. Again, during COVID, this has been incredibly rough for new parents. It's been rough on everyone, but especially new parents that were forced to be isolated. Another factor is a recent loss. This includes all losses: jobs, employment, death, relationship, or any perceived losses. Again, this is especially heightened due to the COVID-19 crisis. We've suffered a tremendous amount of losses over the past year and a half, and we will continue to experience innumerable losses. We feel a loss of normalcy as a whole. We feel a loss of support, of having people in our lives and access, and just so many losses. So this increases the rates of PTSD in the perinatal period. Next, increased stress, socioeconomic status, history of substance abuse. Those with a substance abuse history are more likely to experience having a baby or babies in the NICU and or with birth defects and health complications during or after birth. So again, we touched on those things being traumatic. So obviously being at a higher risk, having a history of substance abuse is something to be aware of. Also, difficulty conceiving. Difficulty conceiving can be very traumatic. All of the things that come along with infertility treatment. Congenital genetic health issues, birth traumas, and NICU stays. I mentioned in my previous presentation, this is the highest risk pool of people who will experience PTSD. And this goes both for mom and dad. And then difficulty breastfeeding. Difficulty breastfeeding can be very traumatic for mom. And next slide, this is very similar to the other one in my other presentation, but can non-birthing parents and partners experience perinatal trauma or PTSD? Yes, absolutely yes. Imagine being the partner of a mom who is giving birth and witnessing these traumatic things firsthand. These interventions, these scary things going on with baby, scary things going on with your partner. Absolutely yes, partners can experience perinatal trauma and PTSD. Adoptive parents can too. They experience the traumas that the birth mom may be having exactly in the same ways. And next, prevention. There's not a whole lot of ways to prevent perinatal trauma, unfortunately, but knowing some of the risk factors, giving adequate psychoeducation, and connecting with resources are very important. So how do we diagnose PTSD and perinatal trauma? Typically it's self-report, and moms a lot of times saying how traumatic their birth was and how much it affected them. Unfortunately, a lot of OBs, from what I've heard from clients, downplay this. They make clients feel like, well, shit happens. Things can happen during birth. It's not going to be perfect. You'll be fine. You're healthy. Baby's healthy, right? You're fine. No, they're not fine. And this is not okay. So this is part of my advocacy work and work that I would like to be seen done by all therapists, that helping moms recognize that, sure, you and baby might be healthy now, but what you went through affected you. Let's help you feel better. We also diagnose PTSD with CAPS or PCL5s, structured interview questions, and rating symptoms of severity, kind of similarly to the way that we would typically diagnose PTSD, but just being mindful that it happened during the perinatal period. So some of the things that you might hear with perinatal trauma include things like, my pregnancy or delivery made me never want to be pregnant again. Before I had this baby, I wanted 2 babies. I wanted 4 babies. I wanted blah, blah, blah. I don't want to do that again. That was awful. I'm terrified to ever even think about it again. I want to go get my tubes tied. I want to do this. I want my husband to get a vasectomy. I never want to do that again. I'm done. That is a message to look for. Next, I had a terrible nurse, doctor, midwife, doula delivery. Okay, tell me more about what made them terrible. Then you can flesh out exactly how it's affecting them. It doesn't feel real. I don't feel like a mom. I get so anxious when I'm not with my baby. I'm not making enough milk. This happened because I blah, blah, blah. This happened because I didn't blah, blah, blah. Blaming themselves is very, very, very common. We need to break those down and challenge those. So, again, how can we help? Here's where you come in. Psychoeducation. Psychoeducation is so important, and I cannot stress this enough, especially with any type of perinatal mood and anxiety disorder. Psychoeducation has shown to be the most effective tool in diagnosing and treating perinatal mood and anxiety disorders, including PTSD. So, psychoeducation to literally everyone. We all know moms, doctors, moms, sisters, brothers, grandmas, grandpas, clients, everyone. Literally everyone, we can give psychoeducation on these matters. You know, a client who has become pregnant or is thinking about becoming pregnant and has already seen you because they have depression, they have anxiety, they have a history of trauma. It's a very easy conversation to have to say, hey, here's what to look out for. These things may happen after pregnancy. It's very common, it's very normal, and I'm here to help you through it. And if I can't help you through it, we'll find somebody who can. Next, screening. Asking those very important questions. Family history, experiences, those ACEs scores. I cannot stress enough how important it is to know a history of trauma. And normalizing how common this is. And then seeking out more training. If this is something that you're interested in, Postpartum Support International offers incredible training opportunities. And while COVID has been a giant pain overall, it has increased access for us to get a lot of these trainings that we otherwise would only be able to get in person. But now you can get them all virtually, which is great. Next, how can we treat these perinatal traumas? I am of the belief that trauma is best treated with bottom-up processing. So typically, top-down processing is a lot of what we do in therapy with a lot of cognitive work and talk work. And again, with that Dan Siegel's handy model of the brain, that a lot of that happens with our frontal lobe, that we're thinking about it, that we're talking about it. But with traumas, a lot of times we haven't processed it through that part of our brain. So we can't even get fully down into most of that. So some of the things that I like to do is in the realm of movement and expressive arts. So just movement, engaging in our senses, any type of movement, not just sitting sedentary. We ignore the healing potential of embodied somatosensory communication when we ignore the experiences of our body. We feel traumas very deeply in our bodies. Calling up on those feelings and when we're feeling them is exponential importance in treating trauma. Movement naturally relaxes the mind's control and begins to tap a deeper level of experience in the lower brain, again, down in this brainstem, and allowing for more free movement to the limbic and higher brain. So we get this central part moving and activated and getting in a good flow. It increases that flow then to the other portions of these brains so that we can get to that top-down processing and we can talk about it. So with expressive arts also, the natural bottom-up reparative process is inherent in all forms of expressive arts therapy. And it begins with the expression of the body's sensory experiences. So drawing, painting, dancing, movement again, all of these are very natural processes to get some of those more embodied somatosensory type things moving so that we can start processing. Talk therapy engages tapping the higher brain through language. And we know through research that when people experience trauma, that language part of our brain often shuts down. And that's why after someone experiences trauma, often they can't talk about it. They feel it. They feel it really deeply, but they can't talk about it. This helps us tap into the ability to talk about it. Also, earlier I mentioned my training in EMDR. In EMDR processing with this population, we use specific protocols to aid parents in healing from traumas held in the limbic system and in out through the neocortex. So we get into that central part of the brain and we get it activated and we get to a point where we can process out cognitively. EMDR has been shown to rebuild the bridge between the neocortex and the limbic system that trauma ruptures. And with EMDR, we develop a safety net for here and now. So we are able to keep one foot here safely with the therapist and then sway into the past. So bilaterally, we get to sway into and tap into some of those body feelings, memories, and processes, and also have a foot right here firmly planted in the here and now so that they feel safe kind of delving into some of those things. It's a really beautiful process. And why? Why bottom up processing? So I mentioned some of this a little bit, but I'll give a few more. So expressive arts, a lot of people are resistant to expressive arts because they feel like they're not creative. I'm not a creative type person. Well, expressive arts are expressive, not creative. Exploration is joyful, with curiosity being the very opposite of fear. So, if we can tap into some of that curiosity and exploration, it can be a very beautiful process to open up new fields. Next, self regulation. Self regulation is one of the most researched facets of expressive arts, that teaching expressive arts therapies can be very self regulating. When clients become comfortable doing some of these things with us, they can carry them back home and use them as self-regulation techniques. Next, overcoming barriers. Again, often the language part of the brain shuts down and is compromised during traumatic events. So clients have a difficult time talking about it, or they can see it playing out in their head, but they freeze and they shut down and they have that trauma response that they freeze and they can't talk about it. Going in through the bottom up and getting into some of that embodied processing with feelings helps us open up those pathways and rebuild those pathways so that we can talk about it, that we can see it and express it with words eventually when it's been very difficult in the past. And then finally, restoration. Using somatosensory or bottom-up processing allows for the potential to move up a ladder to higher levels of processing. So again, building into that somatosensory process in our central part of our brain that feels very automatic and doesn't feel inherently very emotional helps us build those pathways so that we can eventually process out cognitively and then work through some of those things long term. But bottom up processing is, I believe, the very first place that we should always start with trauma. Finally, I have, again, some training and support resources, which I will upload some of these also. Postpartum Support International, again, incredible international organization, probably the oldest one that exists. In 2020 Mom, Mind Body Baby is local to North Carolina. And I've also linked the Institute for Creative Mindfulness. That is where I received my EMDR training and also where Dr. Mara Tesler-Stein offers her advanced perinatal trauma EMDR course as well. Finally, my final words are the same as my previous one, but it's relevant for everyone. You are not alone. This is temporary. With help, you can heal. You can get better. Thank you.